Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement. Art of Oncology podcast presents Susan Sullivan reading the essay At Sea by Alison Lauren, published online before print on January 17, 2017.
I entered the examination room to find him pacing angrily. He gruffly cut off my attempt to introduce myself. "Doc, I got to get back on my ship." After a troubled childhood and an unfinished education, Kevin found his vocation by working on cargo ships. Recently hired by a new company, he was anxious to get back to sea, but an abnormal blood count at his pre-employment physical upended his plans. Just 27 years old, he was diagnosed with essential thrombocythemia. The occupational physician would not clear him to return to work, and soon after, Kevin was found unconscious from a drug overdose. His oncologist referred him to an academic center, and that is how he came to meet me. Kevin worked on shipping vessels all over the world and traveled for months at a time, docking at foreign ports exotic and grim. He required treatment with hydroxyurea because of extreme thrombocytosis and a myocardial infarction during his overdose. But his history was checkered with missed appointments and erratic use of his medicine. Monitoring him with blood tests while he was at sea would be all but impossible. How could I permit an 8-month disappearance on a ship to the Arabian Sea for someone with unpredictable behavior and questionable judgment? But Kevin was insistent, expressing both passion for life at sea and desperation for my blessing. I asked him to compromise. Would he take his hydroxyurea and I would monitor his laboratory tests? In 3 months' time, he would return to see me to reassess his seafaring safety. I was sure he would agree to this fair offer. He exploded, making liberal use of colorful profanities. Kevin conveyed that life at sea was his escape and his protection. His overdose, he growled, was directly related to the prohibitions issued after his diagnosis, to the frustration of feeling trapped on land, and to the onshore company he kept. As he spoke, it dawned on me that refusing to authorize his return to sea might be riskier than allowing him to go. So I signed, and he went. Soon after our visit, I began to regret my decision. I felt bullied into signing his paperwork. I wondered, with a simmering, unpleasant melange of resentment and humiliation, whether he would ever return to see me. Then he no-showed for his follow-up appointment, confirming my darkest thoughts. A few months later, Kevin came back. He explained that he was at sea for our previous appointment, but he had been taking his medicine. Sure, I thought. I steeled myself for the barrage I expected to face, certain that I would have to refuse his paperwork when his blood counts betrayed him. Except they did not. They looked great. His schedule would be irregular, he said, but he would come to see me whenever he was back on shore. And could I please fill out his forms again? That was in 2009. Kevin continued to take his medicine. His blood counts remained controlled, and he felt well. Every kept appointment astonished me, but to a lesser degree each time. Our early visits recapitulated the first, with Kevin evincing anger and threats. Whenever I saw his name on my schedule, I did an inner eye roll. Will he show up? Brace yourself for some attitude. But with each meeting, he was calmer and more respectful. Rather than cagily circling each other in a medical version of the prisoner's dilemma, "I'll let you go back to work if you take your medicine. I'll take my medicine if you let me go back to work." we began to have real conversations. He told me about his travels and asked me about my family. Gradually, I found myself beginning to root for him. The last time I saw Kevin, he asked whether I had a patient of a certain description in the waiting room. I did not. Good, he said in his gravelly voice. The guy is out there screaming at everyone. He's high on something. He looks like he's ready to hurt someone. He paused, sizing up my small frame. You, stay away from him. If he comes anywhere near you, I'll crush his skull. A streetwise guy giving a surly compliment, I thought with a smile. He was heading out to sea again soon. I made some recommendations about his hydroxyurea dose and sent him on his way. On a weekend, not long after that visit, I was absent-mindedly scrolling through emails when I saw a message from Sue, Kevin's mother. The brief note took my breath away. Kevin committed suicide on the 28th. He had sleeping pills filled on the 21st. He took all that were left and shot himself in the head. Shock. And then sorrow. I'd come to think of this rough kid as a good soul who had found a way to survive. His path was steep and bouldered, but he came to an existence that I thought had saved him. I had allowed him to convince me that his peripatetic life soothed his psychological demons. Kevin depicted his life at sea as protection, and I believed him. But in fact, it provided inconstant shelter. Next, did I write that prescription? I replayed our last visit in my head. No, I do not think he asked me for anything for sleep. Hurriedly, I opened my laptop and logged into the electronic health record. Nothing. Relief was immediate, but bittersweet. Was I blameless, even though I did not write the script? Were there signs at our last visit? I replayed our interaction in my head. I reread my note until it was memorized. And if I had written the prescription, what would my responsibility have been? Certainly, I would have felt culpable. But perhaps I was taking this too hard, too personally. But is there such a thing as taking it too personally when your patient commits suicide? Dear Sue, I am so terribly sorry to hear this. I was fond of him, and I'm very sad about this news. Thank you for letting me know, I replied. I looked for an obituary, something more to add to my memory of him. Google came up empty-handed, but I found what I was looking for in his mother's answer. Thank you. Didn't see this coming. Was a terrible shock. I know he thought highly of you. He was my baby, the youngest of 4 boys. Kevin's death forced me to reflect on my decision to allow him back to sea. Physicians willingly take responsibility for our patients' lives, but how do we honor our obligation when psychological needs run counter to physical ones? What if I had refused to sign his paperwork and he had shot himself then? What if I had sent him on his ship and he had had a stroke? I thought I had fulfilled my responsibility to Kevin as his doctor, to take care of the whole person. If he had died as a consequence of a clot or bleeding while aboard his ship, paradoxically, I would have been at peace with that. But his suicide haunts me. Although it was risky to sign those papers that allowed him back on his ship, I wished to honor his autonomy, and I became convinced that in doing so I was saving his life. But I missed the most important sign of all, the moment he was most at sea. That responsibility is mine, even if the signature on the prescription was not.
With me today is Dr. Allison Lauren, a hematologist-oncologist at the Perelman School of Medicine at the University of Pennsylvania and author of At Sea. Allison, welcome to the program.
Thank you very much, Lydia. Thanks for having me.
Thank you. Your piece is so beautiful. We really enjoyed reading it and are so delighted that you submitted it to Art of Oncology. Usually I ask our writers why they write and when they write. So let's start with that, a little personal note. Your writing is so fluid. Have you always been a writer?
That's an interesting question. I think I wouldn't say that I've always thought of myself as a writer, but I always have turned to writing to process and to help me think about things in my life or things with my patients that have been difficult for me to contend with. I think I probably started writing in high school.
I see. Writers are usually readers as well. Do you have time to read? And if so, what are you reading?
I do have a little bit of time to read. I read on my commute because I take the train. And that's been a really precious, although far too short, personal time for me. I just finished reading The Sympathizer, which was phenomenal, and now I'm reading a compilation, The Best American Short Stories, which was curated by Junot Diaz, one of my favorite writers.
Wonderful. We have similar tastes. I just finished The Sympathizer, too, and I also loved it. So tell us a little bit about this story that you wrote about. You wrote about this character, Kevin, a patient who was very young when he was diagnosed with hematologic malignancy, and the story evolves over 6 years. Tell us a little bit about what it was about your relationship with Kevin that led you to write about him.
Well, I think when I first met him, what really struck me was his passion. He was so angry about his diagnosis and just desperate to get back to work. And he, when you first met him, he came across as difficult. I actually saw him with one of my fellows, and so she saw him first when she came out of the room. She was kind of taking a deep breath and saying, "We've got a live one in here." And I guess that was what really grabbed me right away, was that it was so clear that there was really more going on with him. He wanted to just be this quick visit, sign my papers, I have to get back on my ship. But there was so much more to him. It was so obvious. Nobody's that passionate about, I just want to go back to work. And so it really grabbed me that there was much more to him, that he was much more complex than he wanted us to know or believe just in that first meeting. And I don't, I take care of patients with blood cancers, and so I don't see very many young patients, and so that's also something that stood out. It's very unusual to have a young man with this diagnosis.
So it sounds like, at least that during that first interview, I think you would call him a difficult patient, right?
Yeah, I hate that expression because I think it's a shorthand and allows people to sort of write off their patients without taking the time to understand what's making them tick. Everyone who's difficult is difficult for a reason, or usually many reasons. But he was tough, and I definitely had the sense that he was referred to me, I think partly for medical reasons because his community oncologist wasn't really sure what to do with him. But I think also because, I think he had sort of battered his community oncologist, was really tough on him. And finally, I think they just said, go somewhere else. We can't deal with you.
Yes, I love the way you turned that around from difficult to challenging. Then in your essay, you talk about how over time you came to enjoy the visits more. And I wonder if you could tell us a little bit about what happened. What was it, your interest in him that allowed him sort of to warm up to you? How do you explain this sort of transformation in the relationship?
I think it was because I listened to him. I think it was because I showed him that I cared about why he wanted to go back to his ship. This was a guy who had obviously had lifelong issues with authority figures. He hadn't finished school. He had substance abuse issues. He was not a guy who was going to sort of get in line and play by the rules just because somebody told him so. And so I think the reason he sort of came on like gangbusters when we walked in the door was that I think he really thought he was going to convince us. And by showing him that I was willing to work with him, well, tell me, why do you want to go back on the ship, and why is this important to you? And when I floated what I thought was a reasonable compromise and it wasn't reasonable for him, and that I was willing to meet him, what ended up being more than halfway, I think, was what in his mind made him think that maybe I'd be okay, that I was someone maybe that he could work with. And I think I earned his trust by listening to him and by sort of trying to understand what it was that was important to him. I think we have a lot of rules about what patients can and can't do in all kinds of situations, and there's no evidence to back it up. And sometimes you have to sort of trust the relationship or trust the patient or take a risk because it's important to the patient, even if it's not maybe by the book medically the right thing to do.
So how would you describe your struggle to deal with Kevin over the time and to meet him where he was at?
I guess I've always been somebody who questions the rules a little bit myself, even though if you look at me, I'm a consummate rule follower. And so I was interested to understand, what was important to him. And I think that by showing him that I wasn't just interested in checking off boxes, right? I wasn't just checking on his hydria and checking his blood counts and showing him the door, but, that I asked him, where were you on your last trip, and where do you like to go, and what is it that you like about working on the ship? I think those were things that no one had asked him before, at least not in a medical interaction. And so I think over time he realized that I was interested in who he was and not just who his blood counts were.
And he showed that to you in one of your last visits when he told you he worried about this person out in the waiting room who seemed belligerent and he wanted to protect you. I thought that was particularly moving.
Yeah, I was really touched by that also. It was really very sweet. He obviously has experience with rough characters and clearly recognized this guy in the waiting room was unstable. And I was really touched that he was worried about me. That was really, that meant a lot to me. It showed me that he cared about me too, that I wasn't just a signature on a paper to get him back on his boat.
Yeah, that was lovely. Let's talk a little bit about what many readers will probably wonder about, which was this underlying psychiatric illness that never seemed to have been quite diagnosed or addressed. When did you start to think about that, and how did you deal with that over time?
I as you can tell by the way I finished the piece, I do feel responsible for the whole person, not just the disease that I'm tasked with managing. And I have obviously much more guilt about not addressing that openly with him beforehand. It's obvious the day I met him that he was not a highly functional adult person who was able to deal with conflict in a reasonable manner. And as I learned more about his history, it was pretty clear that he had, at the very least, anger management issues with authority, issues with following the rules, and probably some depression as well. But I guess it was sort of two things. One is I really did think he was better. I'm sort of putting air quotes around the word better. Like I thought that he had found coping mechanisms. I attributed a lot of insight to his decision to go to sea. I thought that he had sort of thought about this and said, wow, this is a lifestyle that will keep me out of trouble, that allows me the freedom so that I'm not bristling at the rules all the time. Like I actually thought, wow, what a great solution to his difficult psychological challenges. But I think part of it was that I was afraid to bring it up to him. I knew that we had built this relationship of trust, and I was a little bit worried about alienating him by raising it and saying, gee, I'm worried about your psychological well-being, and have you ever thought about seeing a counselor or considering an antidepressant or something like that. I think I was afraid to damage the trust he had in me by raising those concerns, which is sort of cowardly, I guess.
Let's suspend judgment there for a moment. Is he the first patient or the only patient you've had who's committed suicide?
Yes, I have had patients die of drug overdose. It was never clear to me whether that was intentional or not. He's the only one that I am aware of who's ever intentionally taken his life.
I think it's tremendously difficult for physicians in any specialty to deal with patient suicide. And, it's very difficult to even, I think, process our own feelings of grief over that. I wonder if writing perhaps helped you clarify some of these ideas.
It did. I guess you can tell by my last comment that I do feel a great deal of responsibility for the health of my patients. And when I discovered, that he had taken his own life and I talked to a few people about it, the response was, wow, that's really terrible. But, you can't blame yourself for that. And I mean, blame is a strong word, but I do think that, as a doctor, we're supposed to take care of our patients and help them live healthily and better. And when they choose a different path, it's hard not to have that reflect on who you are as a physician, that maybe there was an opportunity to take better care of them. And I do think that writing about it was both a way for me to process my sorrow and loss, because I really did like him. But it also was a way for me to honor him. You know, he wasn't famous. He didn't have a big life. You know, he didn't have a million friends. He wasn't working in a place where there were lots of people around him. And I feel like this is a way to memorialize him in a way and sort of let people know that he was.
And we really appreciate that. When I, as a reader, thought about your piece, I read it, you know, also with that spirit that you were honoring your patient and that you were bringing to your colleagues into the greater community of oncologists and physicians some of these great dilemmas that we really experience when we're trying to do what's best for our patients, and often with complex needs that span not just the body but also the mind and the soul. So I think I understood that, and I hope our readers appreciate that as well. And the one thing I'll say is that you also introduced this wonderful phrase, and that is that his mother reaching out to you and comforting you in a way helped you perhaps to make sense of what just had happened. Is that right?
Yeah, it really did. I thought it was an incredible kindness for her to share the fact that he did like me, that he did trust me and respect me. And, you know, I think I probably was the only physician that he ever, you know, we had a relatively long relationship, and I don't have the sense that he really was somebody who was going to stick with a lot of those types of relationships. And just the fact that he continued to come back to see me was reflective of what I thought to be his underlying faith and trust and respect for me. But his mom validating that meant a tremendous amount.
Well, thank you so much for sending us your work, for sharing this extraordinarily beautiful piece at sea, and thank you for chatting with me today. This is Lydia Shapira, and this is the end of our podcast. We'll see you or share this with you next time. Take care.